Hello and good evening. Thank you for being here. Got a good little crowd. My name is Pete Rumford, and I'm physical therapist at IPA Physio OC. Thanks for joining us and spending some time with us this Wednesday evening, I guess it is. So we're talking about the foot and ankle, and my goal over this hour is to convey some information, but hopefully not in a boring, dull sense that we all want to get on with our evening, but just to set a background and then have at least 20 minutes at the end or so where we get up, we feel our feet, we do an exercise, a workout for our feet, look at how that impacts our posture, our walking, and that sort of thing. So
the first time.
Get right in it. Now, if I could ask you all, if you don't mind, to hit mute.
He has to ask to hit mute. Someone's.
Okay, and then if you have questions as we go, please type them into the chat box or raise a hand, and I'll keep an eye out. I'll check periodically so that I'm aware of any questions that are arising. So you can see here on the screen, just starting with a little bit of anatomy. The picture on the far left is a picture of the plantar fascia. We've heard of plantar fascia, at least in the context of plantar fasciitis, which we'll talk about in a little bit here. But there's three bands to it. There's one thick central band, and then there's two bands that go out, one towards the big toe, one towards the little toe. Those bands that go out towards the little toe and the big toe actually blend into the muscles that control the big and the little toe. So I want you to remember that later, and I'll refer back to that. That our muscular strength of our foot will enhance the function or dysfunction of our plantar fascia. It's a very superficial element within the foot. There's 4 layers of muscle within the foot, and the superficial fascia lays superficial to that. So it can get blamed on, often for pain in the bottom of the foot. Sometimes pain in the bottom of the foot is not related to the plantar fascia at all. If it is related to the plantar fascia, that pain is most typically back towards the heel. There's a hot spot right at the front part of the heel. Otherwise, pain may arise from other structures, like those muscles that I was referring to, and I will get to here on the next slide as well. Otherwise, I want you to appreciate in these other pictures the many ligaments that are in the foot and ankle complex. Some of those ligaments are meant to support the arch. Other ligaments are meant to stabilize the ankle. Another thing that we'll talk about is ankle sprains and chronic ankle instability. So if you have an ankle sprain and you don't treat it correctly, a decent percentage of people go on to have what we call chronic ankle instability, which it makes you more likely to sprain, less balance, less strong, less resilient ultimately. So this is the active subsystem of foot anatomy. We looked at the plantar fascia and some of the ligaments of the foot. Here I want you to appreciate that there's 10 muscles that start and end within the foot. Those are called the intrinsic muscles of the foot. And then there's an 11th muscle on the lowest image here. That's showing the top of the foot. That's a muscle that helps to extend the toes. But the top 4 pictures show the 4 different layers of muscle within the foot. So every time you step and you engage the ground, there are 4 different layers of muscle that are having to contract and engage and stabilize that foot. Some of those muscles create independent toe function. Those muscles help prevent you from falling, help you balance, help you contour your foot to the different surface that you're on. Because of our culture, because of always being in footwear, because of sedentary lifestyles, our feet are oftentimes very deconditioned. And what we see in a lot of our clients is that they lose access to many of these muscles of the foot. They lose coordination, they lose strength, therefore they lose access to those aspects of their foot that can help them be as resilient as possible. There's 2 muscles that start in there's 3 actually that start in the lower leg and come down and help support the foot. Those are called extrinsic muscles. And I'll allude to that a little bit more when we go through the exercise section at the end. What I want you to know is there's a muscle that controls the big toe that starts in the lower leg, and then there's a muscle that controls the 4 lower toes. If you, even sitting here now, if you curl your toes, you're using those muscles that start in the lower leg. We'll talk about differentiating, finding those muscles versus the muscles that start and stop in the foot, the intrinsics that I mentioned last slide. A lot of times people compensate, and the reason I have this slide on here is they're relatively strong through the muscles that start in the calf and end of the foot. Those muscles help to move the toes. They have a small contribution to stabilizing the arch and the back of the foot, but they're not the primary stabilizers of the arch. So if you're a person who finds yourself curling your toes a lot when you're trying to balance, or even when you walk and you push off, you may be trying to compensate by using these muscles as opposed to the muscles that are in the bulk of the foot itself. All right, this is a slide that defines different foot types. You may have heard of cavus foot, which is a common term for a high arched foot, or a planus foot, which is a common term for a pronated foot. Within our paradigm and our paradigm of physical therapy, I know some people on this call are physical therapists. Some of you are clients. Some of you we've never met, so I'm not sure. But the paradigm that we treat our patients from is more thorough, I would say, than the paradigm that most PTs or chiros function out of. And a lot of that stems from the identification and the classification of foot type, because what we have found, and what Greg Johnson, who developed functional manual therapy with his wife Vicky, found, is that the vast majority, let's say all for the sake of this discussion, all people have a supinated foot structure, which means they have a rigid arch. And the difference between people that walk around with their foot in a high arched position versus a flattened out position is what happens at the rear foot. Some people compensate and roll in with their rear foot and end up weight bearing on the inside of their heel and usually towards that big toe. And that person would be classified in most systems as having a pronated flat foot. The reason that we don't just call it a pronated flat foot is because we recognize that the rear foot is compensating because the middle of the foot is so stiff. So we, on the vast majority, again, let's say all people, we're treating the mobility of the midfoot. And this is a complex conversation, but just know that all feet are going to need enhanced mobility of the middle of the foot. As we get towards the exercise section, I'll grab a foot model and explain that in a bit more detail here. All right, so I want to talk briefly about a couple of different types of injuries that are common, some of the management, some of the contributions, and then at the end, we'll have a little bit of time for questions and answers if there's specific questions related to maybe an injury that you've sustained. Let's start with an acute ankle sprain. This is generally a traumatic injury. It can occur both directions, meaning you can kind of roll the inside of your ankle or the outside of your ankle. You can also get what we call a high ankle sprain, which is actually affecting the ligaments a little higher up the leg. But the most common ankle sprain is where you roll the outside of the ankle. There's 3 ligaments out there. They get stretched. Sometimes they get torn all the way. And it can be very painful. I've had a moderate, I'd say, ankle sprain when I was in college playing basketball. Had significant swelling, had to be off of it. Couldn't do my normal activities for about a month. Subsequently, I've had ankle sprains, nothing as serious, but also managed them better so that the recovery was much quicker. I mentioned earlier, the second bullet point here says chronic ankle instability. And again, if you don't manage an acute ankle sprain correctly, and some of that has to do with how we mobilize the joints of the foot and also how we restore balance and strength, you are more likely to experience chronic ankle instability, which is characterized by recurrent strains, sense of weakness through the feet, lack of balance and proprioception, and those sorts of things. So I put these contributors towards developing or not developing chronic ankle instability because there's a lot you can do to make sure that even if you sprain your ankle, it doesn't become a chronic issue. Whereas sometimes a acute ankle sprain is hard to prevent, like if you land on someone's foot. That being said, again, there's the differences in reaction time of the ankle is partly a factor, and people that are more sedentary, that don't exercise, especially lower leg and whole body neuromuscular system as much, their reaction time is not going to be as quick for their muscles to contract when a ligament's being stretched. We even see, and this is just a little bit of an aside, but one of the reasons we tell athletes not to stretch before a game, whoops, see if I can go back here. One of the reasons that we tell athletes not to stretch before a game is because if we elongate the muscles to a certain degree, that it changes their sense of length, we can diminish the reaction time to that muscle's actual perception to change in length. So if you really stretch a lot before an activity, and then you get into a situation where you we've probably all sort of almost sprained our ankle but caught ourselves, that's your proprioceptors, your joint receptors that sense awareness in space, kicking in the muscles almost involuntarily to right the ship before you actually turn and injure yourself. But if you stretch ahead of time, you can impair that sensory feedback, and so you may be more likely to sprain an ankle. So people that sprain an ankle and don't get it treated appropriately, don't do appropriate rehab, they tend to weight bear more laterally on their foot. They tend to have worse balance, weakness, and they tend to have ankle mobility deficits that's going to make them more likely to sprain their ankle. I'm going to go actually run and grab my foot model. I'll be back. All right. Sorry about that. So in an ankle sprain, you can see the outside of the ankle here. The ankle turns like this. All right. One thing that can happen, and it's been shown by research and follow-up imaging via X-ray, is when you turn the ankle, this bone in between the two ankle joints called the talus, it can actually push this outer leg bone laterally. Okay, so it kind of glides to the outside and pushes the outer leg bone to the side. Okay, the significance of that is in people that have not had treatment stabilization of the ankle, years later, that ankle bone can still be wider out to the side. That means this joint as a whole is less stable because it should sort of hug this bone in between these two bones. But if you have a wider space, you have more space you need to control for, hence leading to possible instability. So when we treat acute ankle sprains, our main goals are reestablishing optimal mobility of this bone here and the ability of that talus bone to glide medially. And sometimes we'll tape up this mortise to really cinch things down while it heals. But if we don't mobilize and we let things just heal in the position that they've been injured, oftentimes those ligaments will heal in a lengthened state and they won't be as good of a stabilizer to check the motion of the ankle. All right, so you see on here, if you're working with a physio, we'll mobilize the ankle, we'll use tape to stabilize, then we'll do a lot of strengthening and re-education. On your own, it's never a bad idea in the first 48 to 72 hours to apply ice. Afterwards, you can use heat or contrast, see what works best for you. I'll demonstrate towards the end a self-glide of this talus bone. So if you do sprain your ankle, it's a pretty easy thing to do is just get on the floor and work on mobilizing that talus from outside to inside to help mitigate the effects of the sprain. And then it's important to really emphasize for an extended period of time, at least 8 to 12 weeks after the injury, balance training, strength training, whole lower extremity, but a specific focus on the foot and ankle. When we talk about plantar fasciopathy or fasciitis, and the only difference really is itis implies an inflammatory state. Now there can be an inflammation at that calcaneal tubercle, which is at the back of the heel where this lowest arrow is on the screen on the right. But oftentimes this condition is characterized by more of a degenerative change in the tissue itself. The collagen has become weakened for certain reasons related to blood flow, related to inactivity, related to foot posture. You can see I put some of these contributors on here. But even with this list of contributors, I treat people with this condition that are not very tight in their calves necessarily. They have good ankle range of motion. I've seen people with flat feet and people with high arched feet have this condition. I think most common in active, healthy people, it's a load issue. And if you start new activities rapidly, like say you're training for a marathon and you have hardly been running, and all of a sudden you're running 5 days a week and you're logging 20 to 30 miles in a week, you may be more likely, you are more likely to develop a soft tissue condition like this. All right. Versus if you gradually increase that load over time, build a solid base and slingshot yourself forward, you'll be okay. Generally. On the other end of the spectrum, we have people who are more sedentary. They may be overweight. They may have metabolic diseases like diabetes, high blood pressure. There may be thyroid conditions, things of that nature, where the soil, so to speak, is not as fertile as if they were otherwise healthy and exercising and eating a healthy diet and all those things. So there's sort of those two ends of the spectrum, and the treatment is going to be similar. The response is often better by that first group than that second group, because we have to address a lot of those underlying factors, including things like diet, lifestyle, stress, sleep, all those things. I've seen too many patients over the years start to get better when they sleep more, when they eat a better diet, when they get their mental health under control. So all those are factors to consider. With plantar fasciopathy, self-care, or with the physio, again, it's a lot of soft tissue mobilization of the calf, the plantar fascia, those 4 layers of muscle of the foot. Sometimes there's a nerve component where, depending on the symptoms and what's going on, the L5 and S1 nerve roots particularly can trigger pain down into the heel and into the foot. So that's something that we need to rule out, that it's not a cause or contributor of pain. Again, a lot of neuromuscular re-education. Think of that as just activating the muscles that have not been activated for a long time, and then training motor control and foot posture. Anti-Pronation taping is a taping technique just to help support the arch, and then sometimes we'll carry that tape up the lower leg. If we have time later, I can demonstrate some of those things for you if you're interested. On your own, if you're suffering from this kind of a condition, I'll recommend, again, ice or heat. Both are appropriate given different situations, different instances. Some people love one, hate the other. I recommend people try both. Because it can be a degenerative condition and it's not necessarily inflammatory, let's see what works best. And sometimes it can even be a little bit of both. Throw some ice on there for 5 minutes, heat for 5 minutes. Self-mobilization, we're going to be using some things later, like a ball. You may not have some of these, so some of this may be more demonstration. There's lots of foot tools you can use, like this little foot dome, to help mobilize the muscles of the foot, the fat pad under the calcaneus, those sorts of things. So I recommend getting into some of those muscles that may be contributing, enhance the blood flow to those muscles, work on the mobility between those layers, because again, there's 4 layers and they all have to slide on each other well and move well in relationship to each other. Oftentimes they lose that mobility. Things like toe spreaders, depending on toe function. You may have had these on if you've gotten your pedicure. They actually work very well therapeutically as well, to spread the toes and work on stretching those muscles that go between the toes. Again, the taping technique, many times you can do that on your own. You don't need a physio to do that for you. You just need to learn how to do it. And then if taping really works, then an orthotic can be a good thing. I like to think of it as a short to medium term fix versus a long-term dependency. But I've used orthotics multiple times in my life. When I was playing basketball more frequently, I had a pair of shoes. I thought they were pretty good shoes. I came to learn that a lot of basketball shoes aren't very good when it comes to arch support. And with the amount of cutting going on, the bottom of my feet were killing me after playing a couple games in a week. So I put orthotics in my basketball shoes for a period of time. I'll tell you a little bit more when we talk about shoes. I've transitioned through shoes periodically. And sometimes if I am working from a more like a higher heel towards more, not a zero drop necessarily, but getting lower in the heel, If my foot acts up, I may throw an orthotic in, or I might tape my foot, but I'm working my way to where I can have a more resilient foot on its own. So I like using orthotics, but again, I don't want it to be a long-term dependency thing. Achilles tendinopathy, again, it can be a degenerative condition. It can also be acute. Some of you have suffered from this. Some of you may have suffered a torn Achilles. That pain is usually in the mid-substance here where the arrow is, or it might be all the way down where that's attaching to the heel. The difference is it's called a mid-portion or a mid-substance tendinopathy versus a insertional tendinopathy when it's right at the insertion of that Achilles. So with this, often there is a calf weakness and calf tightness. That needs to be worked on. That needs to be trained and enhanced. And a lot of times we can help with that 100%, but it needs to be carried over at home. There oftentimes are ankle mobility deficits. There may be limitations in the ability to bend and flex the ankle. Again, foot posture may be a contributor, but I've seen people with flat feet. I've seen people with high arch feet suffer from this condition. This can also be a repetitive stress type injury where, similar to that couch to 5K scenario or that couch to marathon, if you're going from nothing to something big, gradually loading. Otherwise, these soft tissues need time to adapt. They also need time off. They need rest. Overtraining syndrome is a real thing, and it's not a problem with how you're working out. It's really a failure of recovery. Footwear can also be a player here, and the thing to consider mostly, like if you have pain in your heel and you notice it in certain, like if you're walking or you're running, how high is the heel on your shoe? Different shoes have different heel heights, even going across the board with running shoes. Some of them start at about 12 millimeters or 10 millimeters. They go all the way down to what's called a zero drop, where the heel is flat in relationship to the forefoot. If you have Achilles pain and you don't have any added lift in the heel, this being the heel here, you're more likely to put more strain on the Achilles because it's going to stretch it more. So a little bit of a higher heel in your shoe and or a lift under your shoe. There's lots of lifts you can buy on Amazon, and you can get them oftentimes where you can just peel like one layer off at a time and make it custom to what feels good to you. That's a good idea as well. So I mentioned some of the things that we would do, including the soft tissue work for the calf. Also, with regards to putting a lift in the shoe, Kinesio Tape applied with your foot in dorsiflexion, which is like heel down, knee coming over the forefoot, to help assist the spring of that Achilles. I've seen a lot of people benefit from that as well. Ice or heat, if it's acute, if this just happened, apply ice for the first 2 to 3 days. Otherwise, as I said, with plantar fasciopathy, you can try one or the other, see what works for you. Stretching, strengthening. One of the nuances of the strengthening for the Achilles is the eccentric control. The lowering phase is helpful for some people. Doesn't help everyone. Sometimes it's too much, but all that means is you push up on 2 feet, you lift 1 foot, and then you slowly lower on the 1 foot to a count of 5, 6, 7, or 8. You're working on that slow, low load going down. And theoretically, that's going to load the tendon more than the muscle. And that's been shown to be helpful in expediting the healing process, more so for mid-substance tears or mid-substance tendinopathies than that insertional pain right at the Achilles. I talked about a heel lift in the shoe. So one other condition that I want to talk about is Hallux valgus and a bunion. That's when that big toe starts turning inward. And there's lots of contributors here. One is genetics. There is a genetic predisposition. You may know people and you see everyone in their family has this kind of an issue. So we can't deny that. Midfoot rigidity plays an issue, plays a role, because if these bones in the middle of the foot, which are those cuneiform bones, I talked about how everyone's really stiff here, but some people, to get their foot flat on the ground, compensate through the rear foot by turning that heel out. That would be a flat-footed posture. Everyone needs mobility of these bones. When these bones are narrow and stiff, for stability, that big toe kind of goes out and then that little toe starts to come back in, and you start to get this hallux valgus and this bunion formation. A lot of you may have calluses on the inside of that big toe. Calluses tell us where we're bearing our weight and where we're pushing off of. If you have calluses on the inside of that big toe, it may just be a matter of time till you get a bunion if you don't already. A callus is on the skin, a bunion is on the bone, but there's something called Wolff's Law, which is a law of physiology that says the bony structures and the structures within the body will adapt to the stresses placed on them. So a callus formation here or a bunion oftentimes mean you're putting more weight and more load through this part of your foot. And like when you push off, you might be pushing off of here instead of carrying that weight into the forefoot. And we'll look at that in a moment too when we get into walking. So anyways, tightness in the midfoot. You might have stiffness of this big toe, so you can't really push off of it well, and therefore you start to change how you move. Tight fitting shoes, high heels. We'll look at the next slide and have an image of feet in a x-ray, both barefoot and in high heels. It's pretty dramatic. The widest part of the foot should be the forefoot. We throw ourselves in these shoes that are squeezing our forefoot, inhibiting our foot muscles, giving us foot pain, changing the structure of our foot. So that should change. If you have to wear high heels for your job, put them on when you need to, take them off when you don't. Have something under your desk that you can slip into while you're at the desk and do what you need to do if you need to do it. When I lived in New York, I saw a lot of feet that were very dysfunctional because many of the women are walking around in high heels all the time. The most interesting case I've ever had though was a woman with pain in her forefoot here, and the pain was so bad, but the only time she didn't have the pain was when she was in high heels, and she wore high heels all the time, and she couldn't really walk outside of her high heels. And that was a case that I had a really hard time cracking because she was just stuck in that high heeled foot position, and even though it wasn't good for her, her foot had adapted. I had a hard time getting her to unadapt to that. So foot posture, weak muscles, repetitive stress, all of these things can play a role. Bone spurs, but again, big one is footwear. So look at a picture of these feet. It's the same foot, barefoot versus high heels. You can see how the high heels put people into this bunion hallux valgus position. So some people don't want to hear this, but it's unfortunate. The footwear that we choose has a big impact on our foot function. And if we're dealing with pain or we want to enhance our function, we can't keep squeezing our feet into these little shoes, except for occasionally, maybe it looks nice sometimes. Yes. Okay. Treatment involves really mobilizing, starting this with this midfoot, getting all of these bones moving better, and then working on enhancing the alignment of this bone all the way down into the toe, activating the muscles that help to pull that toe out versus pull it in. And oftentimes those muscles haven't really been used in a long time, but those are some of the intrinsic muscles that we're going to work on. So we have to mobilize things, work on the soft tissues, work on the joints to get this more in line, and then activate the muscles. These toe spreaders, which you can put around. I know this doesn't really show it well because I got them in the wrapper. But you can put your toes into these toe spreaders, and it's going to help hold your toes apart. These ones that we use, they got two different sizes to help train those toes to be more neutral and to not come in together so much. So like 15 minutes a day with your toe spreaders keeps the doctor away. Working on your strength and working on some of the self-mobilization that we'll do here in a moment as well. So I wanted to talk briefly about shoes and footwear. Again, and I'm going to talk more about like athletic footwear now. I've hit pretty hard the high heel thing. And it's not just high heels though. It's like men's shoes. I've got these nice loafer looking shoes, but when I put my feet in them, my big toes hurt, and they hurt for a day or two after wearing them. So when I want to get all dolled up, I'll put them on, but I know I'm going to pay the price and I know what I need to do afterwards. But in my athletic shoes, in my running shoes, what we're looking at is a lot of times the heel is about twice as high as the forefoot, and at least, and we want to theoretically be able to work our way down to where that's less than a 2-to-1 ratio. That may take some time. It doesn't mean going from a really thick heeled shoe down to a 0 drop shoe and that's it. and go out and run 6 miles, you're probably going to hurt your Achilles most likely from that scenario. But it's working into an enhanced mobility and an enhanced function of the foot in its natural state. So I do believe that that is a good thing. It just takes time to build that resilience. The midsole, some people love really comfy shoes, and there's nothing wrong with that, like a Hoka, something that's got a lot of cushion. The only problem with cushion is it decreases the feedback of the ground going up our chain. So if you're someone with balance deficits, if you're someone that has any kind of neuropathy or something like that, a shoe with a lot of cushion and or a rocker bottom may not be very good for you. It may actually impair your balance more and not give you feedback. So it's a little bit of a balance you've got to strike there. The forefoot width, wider is better across the board. You don't want to be in a shoe that's causing your toes to get squished together. You want to be in a shoe that allows for your toes to function in their optimal natural state. Posting, less maybe more when I refer to the posting, that's just the part in the middle of the shoe that sometimes is very hard or firm or plasticky. There's lots of different types of shoes. Basically, there can be a minimalist shoe with minimal support, like a Nike Free, and even on the far end, like a Vivo Barefoot. I'm wearing these right now. I can show you in a little bit. And then there's a neutral shoe, which has some support, midfoot support. And then there's a motion control shoe. Those motion control shoes have reinforced materials like plastic to help keep the midfoot from collapsing or the rear foot from compensating, like we were talking about. But less may actually be more. Studies have found that people get more injured in those shoes that have that type of extra support. I try to work people towards a neutral shoe or a little bit between neutral and minimalist. The lighter is better for the weight, obviously, particularly if you're running. Any little bit helps to enhance performance. Make sure that when you're buying shoes that you have a ½ inch between your longest toe and the end of the shoe. Just like the shoe shouldn't squish our feet in, we don't want it putting pressure on the end of the toe. That's a good way to develop first toe arthritis and problems like that. Couple of side notes, durability. If you're a runner, get new shoes every 300 to 500 miles. That would be true of people that walk a lot as well. And if your foot's strong, you have many options. So if the shoe is that important to you, that may be a problem of your foot not being strong enough versus any particular type of footwear. So let's start with the foot. Let's get the foot stronger, and then let's find a shoe that's comfortable. I said, if it ain't broke, don't fix it. The only caveat there is, like, you may like a certain shoe style from, like, I use this example a lot. I like the Nike Pegasus back in 2017. I hate it now. They keep changing and modifying, and I think from their point of view, enhancing the manufacturing of the Pegasus, but it's just changed, and I don't like the way that it feels on my foot anymore. Same with the Nike React. So I've started running in New Balance and Brooks and a wider forefoot, and I'm playing around with different shoes because you can't just pick a model and buy it every year. They keep changing and adapting, and that may not work for you. And then be aware that 20 to 30% of shoes are defective. I'm not going to go into it here right now, but there's ways to evaluate a shoe to make sure that it's balanced in a way that it's not going to affect and negatively impact your foot. I do believe that these shoe manufacturers know, because the same shoe can be made at many different factories all over the world. Not all factories make the shoes as well. Those shoes that are defective, I do believe they end up in the outlet stores. So you're not paying as much for them, but they're not as quality. And that can be a source of injury. So should we always be barefoot? I love this book. It's a great story, Born to Run. It came out probably 10 or 15 years ago now. A lot of people, this started the barefoot craze, and people started running in their Vibram 5 fingers and that sort of stuff. I believe it's a reasonable goal to become less dependent on our footwear. And that, as I outlined, like what to look for in your shoes, that's a good goal. But we need to build the resilience of our feet and transition slowly into the activities that we choose to do versus going all at once. But the stronger that your feet are, the stronger you will become. Your whole body will become stronger as you work on strengthening your foot. So here we're going to transition now into evaluating a couple different aspects of our feet and our function and our mobility. And then we're going to go through a short foot workout, and I'm going to demonstrate some self-mobilization techniques. If you have anything like a bouncy ball or a lacrosse ball, a tennis ball, even if you have like a foam roller, I have this one that vibrates. You may want to grab those things and participate in that part. We'll be going through some strengthening for the intrinsic muscles of the foot as well as the muscles around the foot. And then I'll take a little bit of time to go through our standing posture, how we should weight bear through the feet, and how we should use our foot to function most efficiently when we walk. So these are the motions that we'll look at on ourselves, and you don't need to measure it necessarily, but I want you to get a sense as we go through here in a minute. Is one tighter than the other? And you could measure, if you did measure, ideally you'd have about 4.5 inches of mobility where that knee comes over the toe. And most importantly, I want you to have symmetry between the 2 feet. You should have good mobility of the big toe. When the knee is over the toe line, you should have at least 30 degrees. If your big toe is stiff and it can't lift off the ground like that, it's going to impact how you move. It's going to impact how you push off. We're going to look at being able to isolate the big toe in standing and sitting, and then isolate the little toe, and also the ability to really spread our toes. How well you can spread your toes is a really good indicator of how strong your foot intrinsic muscles are. Then we'll conclude with looking at a self-check for alignment as a whole, but with particular focus on how we're weight bearing into the feet, and then also how we push off. This is a check I use with runners. It works just as well with walkers, and we all walk for the most part. So we'll look at these different components here as well. Again, if you have some of these tools at your disposal, you may grab them, self-mobilization tools. I talked about orthotics. The point of this slide is just to say there's a lot of things out there that can help. There's things I haven't heard of, I'm sure, that can help. I taught a class last weekend on this, on the whole lower extremity and foot function, and got a few recommendations from course participants on other types. These toe spreaders at the bottom I hadn't heard of, but you can actually keep these on while you're wearing your socks and shoes. So that's pretty helpful as well. These are low profile, but they're probably not going to fit in your shoe. All right. So here's going to be our quick workout. I'll take this off the screen. I'll stop sharing my screen so that you can see myself more. Okay. And I'll come to a place where we'll be honing in. Let's see. And right now, I would encourage you to participate. What I'd like you to do is take off your socks and shoes so that you're barefoot. If you're not already, you all are probably home and comfy, hopefully still paying attention. So these are called Vivo Barefoot. These shoes, the heel to toe it's a 0 drop, so the heel and the toe are at the same level. You can tell how flexible it is. You can move it any which way. It's got a very thin sole. It's very wide in the forefoot. So I've been playing around with these more and more. But as I've worn them, I transition. I don't wear them every day of the week. If I do, my right foot, which is a little more problematic, as I work through strengthening, will bark at me. I'm on my feet all day. So, but as I've been wearing them now for about a month and a half, that's happening less and less. My feet are getting stronger. So I like those shoes as one of the alternatives to like a Nike Free or something that's got a little more cushion to it. All right. So I'm going to be back here. At times I'll try to hone in on my feet, but I'll also do my best to describe things as well as I can so that you can just follow along. You may or may not have good visibility of my feet right now, but go ahead and stand up. And what I want you to feel, first of all, is where do you tend to bear weight in your feet? Do you tend to have all the weight in your heels? Do you tend to have all the weight on the outsides of the feet, the insides of the feet? Or is it going straight through the front of the heel, the base of the big toe, and the base of the little toe, the foot tripod. All right, I want that tripod of weight bearing. So your weight should be a little bit forward if you found that it was in your heels, so that you feel like you're engaging the toes, but most of the weight is distributed between the base of the big toe, the base of the little toe, and the heel. All right, now lift all of your toes, and I want you to feel if you've got your weight in that tripod and you lift all your toes, can you feel how that lifts up on your arch? It actually elevates the arch of the foot. Now lower your toes, keeping them flat. I'm going to get rid of this pad for a moment here. It's too soft for me to have good feedback, kind of like too much cushioning in a shoe. So if you lift all of your toes, that should elevate the arch of your foot. And then I want you to lower your toes flat while maintaining that arch of the foot and the weight in the tripod of your foot. Now keep your big toes down and lift your little toes without lifting the outer border of your foot. So you're splaying the little toes upward while the big toes stay down on the floor. This is big toe isolation, and the two biggest intrinsic muscles of the feet attached to the big toe. So what we're doing here is really hyper engaging those muscles of the big toe while the little toes are lifted, and we're keeping that up for about 30 seconds or so. Now keep the big toe down, lower the little toes, and pick them up, and do that on and off 10 times if you can. If you're having a hard time doing this in standing, go ahead and do it in sitting. It's a little bit easier. You might find you need to like kind of use your hands to help support as you're learning to feel that. You'll see like even my hands will try to help as I do this, okay? So that's big toe down. Now I want you to lift all your toes and lower just your little toes, keeping the big toes up, but don't roll to the inside of your foot. Still got weight in the tripod, big toe, little toe, heel. Big toes are up, little toes are down. Keep the little toes down as you lower and lift that big toe 10 times. 7, 8, 9, 10. Okay, now lift all your toes again. And now try to lower just your big and your little toe so that you're spreading and fanning your toes as much as you possibly can. You can see how my middle 3 toes on each foot, hopefully you can see that to a degree, are up. My big toe and my little toe are spread out. What we're doing here is there's a toe on the inside of there's a muscle on the inside of the foot and the outside of the foot that pull the big and the little toes out. They're called the Abductor Hallucis, which is big toe, and Abductor digiti minimi. Those toes have attachments to your plantar fascia. Those muscles, have attachments to the plantar fascia. And so strengthening these muscles are going to help to strengthen your plantar fascia. And again, if you're having any pain, if you have plantar fasciopathy, fasciitis, you can do these in sitting too. Now go ahead and relax and just kind of march in place here. All right. So that's called the foot coordination series, or some people call it toe yoga. And I didn't come up with it, but I learned about it, and it's something that I use a lot. You're keeping the big toe down, lifting the little toes down, lifting the big toes, and then trying to spread your toes. Now you can do things where you curl your toes, but when you curl your toes, you're strengthening more the muscles that go into the calf versus the muscles that start and stop in the foot. And I want you to be aware of that because, again, a lot of people tend to really curl their toes when they do something like a heel raise, which we're going to do in a moment, and they're substituting stability of the foot for activating those muscles in the lower leg. All right, now I'm going to sit down for this series and come to a place where you can see my feet. So what I want you to do now is you'll be sitting with your knees over your feet, about over the toe line. And I want you to lift your toes, lift your whole forefoot actually, and bring your feet together to where the big toes can touch, and then lift and rotate out as far as you can. knees should stay relatively facing forward, but it's like you're picking your feet up, lifting them over a line and going out and then going in. So we're working on rotation of our lower leg and the muscles that are along the front of the shin, as well as working some of the stability through the back of the leg and a muscle called the posterior tibialis. And if you feel like you're having a hard time lifting, you can bring your toes, feet a little bit further out in front of you and do the same thing. It's just going to get a little bit progressively harder as you bring them back, heels more underneath you. But I want you to go through, we're going to go for another minute where you're getting to where you touch your big toes and then you rotate out. Touch your big toes, rotate out, touch your big toes, rotate out. All we're doing here is working on strengthening and enhancing the muscles of the foot and ankle, the front of the shin, as well as muscles in the back of the knee that control rotation of the knee. Many people, when they walk, they don't have good control over their foot. Maybe their foot's like rotated out and then their knees rotating in. And that opposite rotation is not a good situation for the knee. The knee gets into a bad situation because of how the foot moves and how it stabilizes. Okay. Now pause there. I'm sitting. If you're sitting, you can do this. Otherwise, you can check it later. But what I want you to see with regards to your big toe mobility is if your knee is over your toe line and you bend down, can you lift that big toe and guesstimate about 30 degrees of mobility? If you can see on the screen, you may be able to, you might have a hard time. I've got plenty of flexibility in my big toe. But if you feel like you try to lift your big toe and it only goes up like 10 degrees off the ground, you may feel a big stretch underneath your foot. That would be soft tissue tightness. You may feel pain on the top of the toe. If you feel pain on the top of the toe, that may be like a joint stiffness issue. It could even be that there's some bone spurs or arthritis there. So the point would be we need to, and this would be an instance where it'd be worthwhile to come in for an evaluation to see how we can enhance that mobility without aggravating things so you can start to use that big toe again and use it effectively. Now, if you put a piece of paper down on the ground, you could stand far away from the wall. You could start arbitrarily at about 4 or 5 inches and see how far over the foot your knee can go without lifting that back heel, and then measure that. Again, the accepted norm is about 4.5 inches. But most importantly is symmetry. If you can go 5 inches on one and 5 on the other, that's great. 3 on one, 3 on the other, both can improve. But if you go like 5 on one, 3 on the other, something's got to change, because every time you squat, you're probably going to have a predilection to bias the side that has more mobility as opposed to the side that doesn't. Okay. So we'll talk in a moment here about some of these self-mobilization techniques, but for now, those are the two most important ranges of motion to have in the ankle: extension of the big toe and flexion of the knee over the ankle. All right, back to some strengthening. If you have a wall or something you can lean on, I want you to lean at a slight angle. If you don't, you can definitely do this vertical and maybe hold onto a chair or something for support. Usually when I do heel raises though, I have people at a slight forward lean because that's how I want them to, that's how they walk. We walk going forward. We don't just go up and down. So I try to simulate that. But what I'd like you to do is push up onto your toes and hold for a moment and just see, ask yourself, where's the weight in the foot? Have you rolled to the outside of your foot? Or have you stayed with weight equal between the big toe and the little toe for the most part? As you go from heels down to heels up, the weight should transfer through the middle of the foot. Don't roll to the outside. That's the most common problem that I see. If doing 2 legs is easy, let's pick up the left knee, and the left knee comes up and the left toes go up. Don't leave the toes going down. Straighten that right knee by engaging your thigh, and I want you to push up and down and do 10 of these. 2, 3, 4, 5, 6, 7, 8, 9, 10. Lower the left leg if you're doing single leg. If you're doing 2 legs, take a break and then you can get back on with us. Bring the right knee up. The knee should come up high enough that you feel the opposite glute kick in. Tighten the thigh with the quad. And I want you to push up onto the toes, equal weight between big toe, little toe. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Hold that 10. Notice if your knee's still really locked out straight. I see many people start to bend their knee as they push on their toes. That's weakness of stabilization of the calf. And well, the way that the calf affects the knee and the ankle. So if you can't keep the knee straight while you're driving off your toes, you're not going to effectively propel yourself using the foot. All right. So basic exercises, coordination series of the foot, the up and over, working ankle dorsiflexion and in and out, doing the heel raises. And then the last thing would be, as a basic starter, is just balancing, but balancing in a way that you've engaged your intrinsic. So if you put your right foot in front of the left and you shift your weight forward, I want about 80% of the weight in the right foot. Lift the toes of your right foot. Feel how that lifts the arch. You could then either try to just keep the arch while you lower the toes, or try to spread your toes and do that toe spread combined with lifting the left leg and doing single leg bounce. So you've got single leg bounce combined with an exaggerated activity of the intrinsic muscles of the foot. And the goal would be to hold this for a minute. We'll just do about 30 seconds right now. And then working towards even eyes closed, intrinsic engagement, single leg balance, barefoot. Okay, lower the left in front of the right. Shift your weight forward, equal weight between big toe, little toe, heel. Lift your toes, feel how that lifts your arch. Spread your toes, trying to keep the middle 2 to 3 toes lifted. Big toe down, little toe down. Balancing on one leg with an exaggerated intrinsic activation. And again, goal would be a minute. We're just doing 30 seconds right now. But feel how much that foot has to work, and feel when things start to tire out. Like my intrinsics start to tire, my legs start, or my toes start to drop. I've got to kind of reset, pick them back up. Makes balance a lot harder, but makes you engage things a lot more. Okay, lower that foot down. Now, I want to talk about just a few mobilization tools for the foot, for the calf, and then we're just going to go through some walking. And I want you to feel how you're transitioning that weight through your foot. But if you had a lacrosse ball, a bouncy ball, a tennis ball, baseball, whatever, put it on the ground and have it under your foot. All right, hopefully you can see a little bit from the side here. A lot of people will just roll like this. And I don't think there's anything wrong with that, but I don't think it's doing anything. What I want you to do is feel with the ball where it feels a little tight or a little tender. And I want you to pause there. The pause is to sustain the pressure, to actually change blood flow, water distribution, those sorts of things, and compress the different layers of muscle. And then I want you to just move your toes up and down. Remember, the more you move your toes flatly without bending them, the more you're going to activate the muscles in the foot, which is where you're putting the pressure right now. But you sustain pressure on that tender point for at least a minute. You can roll around that tender point, but in a tiny range where you're not really ever giving up the spot. If you don't sustain pressure on a spot for an extended period of time, you're not going to create any lasting changes. It may feel a little bit better while it's on there or right when it gets off of there, but it's not going to feel good much longer than that. Whereas if you sustain pressure and you keep this on there for a minute, sometimes even 2 minutes, till the pain dissipates by at least 75%, then you're actually going to start to see some major changes that last versus being just very transient. So what I recommend is find a few areas on the bottom of the foot. Ideally, actually, this would have been nice to do before the exercises. but I don't know if all you would have this access necessarily. Find a spot, sustain pressure. I got a really good one right under that big toe, under the inner arch. And then I can move my toes. I can move my knee in and out and work on that mobility as well. Now, if you found you were tight in that big toe, this would be a great place to kind of stretch that big toe. Particularly, you can bring it into a position where the knee's further over the toe. That just lengthens the tendon more. And you can kind of stretch the toe while you're applying pressure with the ball. And hold that pressure and just go on and off with a little bit of a lift of the toe. All right, you can also use this ball or something like this. I like these Hyper Ice vibrating balls where I can sit on the ground, get it under my calf, sustain that pressure. And before I go for a run, if I'm dealing with any kind of tension or tightness, I'll spend a few minutes, again, staying on one spot, moving the foot up and down, while that vibration and the pressure is working on bringing blood flow, enhancing some of the fascial mobility in the calf. You could use like a strap and kind of pull up on that calf too. Just as the toes come up, you lose the ability to get some of the deeper muscles in the lower leg. All right, again, I like these. These are very useful. You don't have to have one. You can just use a lacrosse ball and get the same kind of pressure. You just don't get the vibration, but you can get some compression on an area of the calf and then pumping that foot up and down like this. All right. Now, if you had limitations in mobility of the ankle here, that may be more related to like the joint of the ankle, but it may also be related to tightness in your calf. So the one nuance of stretching the calf, whether you're stretching like here, you might even put something under the forefoot just to exaggerate that stretch to a degree, is hold that stretch for at least a minute. I'll have people usually do this up to 2 minutes, but alternate with a little bend in the knee every 10 seconds or so, and then straighten it back. Okay, what that's doing is it's biasing a different muscle in the lower leg. You'll feel more of a stretch when the knee is straight, but as you bend it, you'll feel a little bit of the stretch go lower towards the Achilles. That's more your soleus. And then as you straighten it out, you're getting more your gastroc, which is your calf muscle. So keep your stretching a little bit active. Like a down dog, pedaling the knees is a great option as well. Now, the last thing I'd like to go through is have you feel on yourself like walking, and as you walk, how the weight transitions through your feet. So I had this little gait check, and I'm going to stand here. I'm just going to read it off, because if I go walking in there the screen, I don't think it's going to do you any good anyway. But if you're still following along and you have a little space to walk more than 3 or 4 strides, this is what I want you to think about while you're walking. Do you land with your feet underneath your body? Or is your foot too far out in front of your body to where you're landing on like the back of your heel? You should feel like you're landing with the weight a little bit more towards the front of the heel and transitioning from the middle of the heel to the middle of the forefoot. Do you feel that weight moving from the middle of the heel to the middle of the forefoot? Do you feel yourself push off as you leave that leg behind of the middle of the forefoot? Or do you feel yourself kind of turning your foot out and rolling more towards the bunion that you might have? Or do you feel yourself rolling towards the outside of the foot? Are your feet and knees facing symmetrically forward? Or is your foot going out, knee going in? What's the alignment straight down from your hip as you look down at your feet and your knees? Are your knees vertically aligned between your feet and hips? And is there a maintained space between your knees at all time? That's a little bit harder for you to maybe see unless you're walking like towards yourself in a mirror. But many times the knees start to collapse and cave in. All right. So with regards to the foot and the lower leg, those are the main things that I want you to consider. What I'll ask you to do is, those of you that were on this tonight, if you'd like us to send you the slides, just send an email to oc@ipa.physio after we're done here. And Hannah, when she's in tomorrow, can send these slides so that you can have that like posture self check walking self-check. And if you found anything else helpful or you were taking notes, you can just keep that going forward. So that's all I have for you all. It's 8 o'clock, and I'm here if there's any questions. So I'll allow you to unmute yourself if you have a question. Otherwise you can leave a chat. I'll hang out here for a minute or so, and if there's any questions, let me know. And if there's not, then thank you for being here. And you can contact us again, IPA Physio OC. We'll be doing a few more of these and then hopefully get back to some in-person classes here pretty soon. So. All right. Thanks for being here, guys. Have a wonderful evening. Goodbye.